All right, welcome everyone to the next episode or next show of Three Surgeons and a Microphone, featuring Dr. Sam Jejurikar from Dallas, Texas, Dr. Salvatore Pacella from La Jolla, California, and me, Sam Rhee, from Paramus, New Jersey. And today is our special Happy Father's Day edition. So we're talking about dads and what we can do for dads and what dads might want or need. So happy Father's Day to you, Sam, and happy Father's Day to you, Sal.
Happy Father's Day to both of you gentlemen. Hope your families are celebrating in style with you. Well, your family's probably not up yet, Pacella, but of course.
Happy Father's Day to both of you guys and everybody out there. Thank you.
Right. As always, our disclaimer, this show is not a substitute for professional medical advice, diagnosis, or treatment. It's for informational purposes only. The treatments and results may be based on circumstances, specific situation, and the healthcare provider's medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified healthcare professional with any questions you may have regarding medical care, and never disregard professional medical advice or delay seeking advice because of something in this show. So now that we have that over, happy Father's Day, Sal. I know you wanted to get things rolling a little bit here.
Sure. Well, for all of our listeners and viewers out there, male cosmetic surgery is something we're going to be talking about today. And it's something that the three of us and most plastic surgeons see with ever increasing frequency. Men, I think, in today's day and age are really interested in staying youthful and being competitive in the job market. And it's fairly common to proceed forward with some cosmetic procedures. So what I wanted to first do is ask you guys, why do you think men get cosmetic surgery or aesthetic treatments?
Yeah. Well, if you don't mind, Sam, I'll start with my answer to that. I think there's been an evolution in my practice, at least over the last 10 years. 10 years ago, there were still a lot of male patients, but they were getting sort of a limited range of procedures. You would see them getting things like Botox or eyelid rejuvenation, some liposuction, rhinoplasty, but things sort of geared towards making them look younger and slightly more competitive. But over the last 10 years, I think as society has moved along and there's been more acceptance for aesthetic procedures, men, just like women, want to look better. Now, the procedures are different, but now we see, high definition liposuction to sort of be geared towards looking more sculpted, or we see a lot of hair transplantation or implants in a variety of muscles to make them look more buff. I think ultimately we're all people. We're living longer. We're a healthier society, and looking youthful and looking the way we want to is more important to men just as much as it is to women.
I'd have to second Sam. I agree 100%. I mean, when I see men in the office, they generally feel good. They feel like they felt, 10, 15, 20 years ago, but they don't have the outside reflecting what they feel on the inside. And so when they see that, that's when they're starting, and a lot of them have tried many different things. They have been doing their nutrition. They have been doing their fitness. They have been doing other things. And they still see signs that don't reflect how they feel. And when that happens, that's when they start looking for treatments. And that's where we come in, basically.
Mm-hmm. Yeah, 40 is the new 60, or in my case, 60 is the new 40. I feel much older sometimes.
You said it.
Okay. Well, so, what's interesting in my practice is, there are definitely a subset of procedures that men do more frequently than women. And I think that's mostly for me in my practice, doing a lot of faces, a lot of facial and eyelid surgery. I think men wear their age the most in the eye and periorbital region. It's just, we have ages of stress and anxiety kind of coming all the way down here. And, Botox, non-surgical treatments really can rejuvenate that. And the eyelid is, to me, I think the biggest bang for your buck when you're talking about a man. The other thing is, I think it's important in the philosophy of male plastic surgery is you can't really take operations that we do or surgeries that we do in women and directly translate them into men. They have to be modified in some way. So as not to cause men to be looking odd or overdone. With men, the key is subtlety, in my opinion.
Oh, absolutely. There's no doubt. Even with the non-surgical stuff, you can't do it exactly the same as you would, when you're looking at the different genders. Like if you tried
like that,
exactly the same.
We want men to look like that.
We don't really want women to look like that either. But to your point, Sal, I mean, you look at, there's many famous male celebrities, and I won't go through the list here, who've had aesthetic procedures where they look feminine when the procedure is done. And so completely agree. You do the same thing in a man as you do a woman, you have a very feminine looking man.
Right. Okay, perfect. All right, guys. Well, thank you for your comments. So what I'm going to do here is I am going to share my screen. Okay, so, and we got a few cases to share here. So, okay, perfect. All right. Okay, can everybody see that?
Yeah.
Yep.
Okay, great. All right, so we're excited today to talk about the daddy do-over. So, kind of a complementary procedures in plastic surgery that we do to the mommy makeover. So let's just jump right in here. So here's a gentleman in his mid-50s and very unhappy with the appearance of his eyes. So Jersey Sam, why don't you maybe tell me what you think about his eyes?
Yeah, so he has a lot of signs of facial aging. As you said, he has a lot of excess skin in his upper eyelid area. You can see sort of how heavy his upper eyelids appear. And in addition, his lower eyelids, you can see the festoon, or the bags are called festoons, in the lower eyelid area, deep, dark furrows. The lower eyelid itself looks pulled down, and he looks unhappy, like extremely unhappy, even though he's probably totally in a good mood right now.
Right. Texas Sam, what do you see?
So I'd echo a lot of the sentiments that Jersey Sam said. I guess this name is going to stick, Jersey and Texas Sam. I like that. This is a very challenging case. Some of the biggest things that sort of pop out to me is, number one, when you look at his lower eyelid position, he's got profound malposition of his lower eyelids. And as I'm sure you're going to talk about as we move forward, lower eyelid surgery can be incredibly complex. If you don't do something to support the lower eyelid at the time that you try to get rid of those festoons or the prominent fat of the lower eyelid that Sam was referring to, you can have a very, for lack of a better term, jacked up looking eyelid when we're done. So I'm going to be very interested to see how you dealt with lower eyelid support in this gentleman. Mm-hmm. The other thing, which I always find to be challenging, is when you look at his upper eyelids, we always sort of focus on the eyelids, but brow position has a lot to do with it as well. So this gentleman, when you look at the outer portion of his upper eyelids, you can see that much of the lower eyelid skin, the lower forehead skin, has actually creeped down onto the upper eyelid. If you do a traditional brow lift in a lot of men, you can have him have a very feminizing look if you raise the eyebrows too high. But it's challenging. He has generalized descent of his entire face, and there's going to be a sort of a structural approach that we would need to take to fix this. First, starting with the lower eyelid position, and then the brow position, and then eventually dealing with excessive fat in the upper and lower eyelids.
I'm also interested to see how you address the ptosis, because that's always a challenge for me with the upper eyelid. Like, ptosis is the overhang of the upper eyelid almost encroaching, as it encroaches on the eye or the pupil, which is the dark circle part of the eye. The farther down it goes, and you see it in older patients, it actually blocks their vision. They have difficulty seeing. And, correcting that is always a challenge. There are a lot of different ways, and I'm interested to see how you address that.
Sure. Well, so I'm just going to run through for you guys and our listeners just how systematically I approach the eyelid and kind of what I'm looking for before we sort of dive into the case. So, you both really assess this perfectly. And to reiterate a couple things here, objectively and quantitatively, we can measure some of these changes. For example, when we're looking at the eye, there's a way to describe eyelid aging. And, one of the things I first like to look at is just the overall frame of the eye. And that includes the eyebrow and the lower lid. But if you look here, just imagine this gentleman's skull behind here. And this would exactly be the hole of where his globe would go into. So overall, although he looks like he's got some fatty lower eyelids, he's actually a bit skeletonized. What we mean by that is his fat is there, but it's not doing what it needs to do. And so part of our approach with eyelid procedures is to use the fat we have. We don't want to take out fat necessarily, but we want to maybe redistribute it into an area where it's going to blend into these creases. And we also may want to add some fat in order to augment this area. Another thing I look at when I'm assessing an eye, and this is sometimes a little counterintuitive, is we want to look at the overall shape of the eyelid right here. And one of the first things I look at is something called the canthal tilt. If we were to look at the distance or the angle from this point, which is what we call the medial canthus, to this point, which is called the lateral canthus, we draw an imaginary line through that. And one of the signs of eyelid structural loss is when that angle comes in downward sloped like this, okay? And in men, we want a canthal angle to be almost horizontal, if not tilted up, maybe a smidge, about 1 millimeter. Women, we want a slightly higher tilt. So we know, looking at this gentleman's canthal tilt, that's going to be down quite a bit. And we want to set that lower lid position up a bit higher at the corner. Now, Sam, Jersey Sam, you made a very important comment about something called ptosis. And what he's referring to is the upper eyelid here. Can you guys hear me still?
Yes.
Oh, okay, great. All right. So looking at the upper eyelid position. So there's an objective way to measure the ptosis in any patient. What we look at is this dot of the pupil right here, and we measure the distance to the upper eyelid position. And that should be roughly about 3 to 4 millimeters. So believe it or not, this gentleman has very limited ptosis, if any. His eyelids are in pretty good position. I think what we're seeing here is the fact that he has such a downward canthal tilt. It makes this area look pulled down. And so I talked with him about performing a ptosis procedure and determined we were not going to do that at this point, just because if we get the canthus set up in position, we remove the skin, we address the brow, I think that sort of goes away. And in general, they talk about bedroom eyes or Elvis eyes. So a little bit of ptosis in men is sometimes attractive.
That's a good point.
Yeah. All right, so let's just kind of run through a couple things here. In tribute to Father's Day here, I've got these two jokers to my left in this picture, and I wanted to talk about some of the age-related changes we see in eyelids. Now, unfortunately, I got sunglasses on in this picture, so you can't see my eyes, but you can see just how bad my eyes are when I go back to the live view. So here's this little guy. This is my son Grady. And little jokester. And if you look at a youthful face here in Grady, if you see here, many young people have this little line right here, okay, right underneath the eyelid. And that is not a line of aging. That's a normal, anatomic, very natural, very youthful appearance. This is caused by the muscle of the eyelid called the orbicularis muscle. So this little bit of indentation here is something we don't necessarily want to fix in people. It's called the orbicularis roll. If Grady were aging, you would see a lot of darkness or a lot of depression in this region right underneath that area. The other thing you can see in Grady here is he's got some really nice fat in the upper portion of his eyelid and the lower portion. So in general, youth means good facial fat. Mm-hmm. This is my dad right here to the left, this handsome chap. Okay, and you see here he's got some signs of facial aging as well. So compared to Grady, he's got that orbicularis roll right here, but he's also got quite a deep roll, or what we call a tear trough, right underneath here. You can also see some of this wrinkling developing right here underneath the eyebrow. So if we were to think about doing some cosmetic surgery on good old Pops here, we'd probably want to address the upper eyelids, the brow, and the lower lids together. So now when we look at fat of the eyelid, what we see here is there's several fat compartments in the face. The ones we want to address are fat compartments 1 and 2. So whenever we do a standard lid procedure, we want to maybe think about taking this fat in the inner portion of the orbit and re-draping it into zone 2 here. The reason being is there's a little membrane across zone 1 and 2 right here called the arcus. And when we reposition fat, we want to release that membrane. So to me, one of the critical things we want to do during any lid procedure is release that little membrane here. That's what allows us to really separate the position of those two zones and blend in the eyelid to the cheek. So here's a little short video of adding some fat to the eyelid here. So this is actually a female patient, but you get the point here. So we're taking some fat we may have removed from the eyelid, and we're replacing that as a little bit of a graft into that area called the tear trough. And that works really, really well to blend the junction between the eyelid and the cheek.
Now, Sal, why do you prefer to do that as opposed to just doing some fat grafting, using a cannula? What's your preference for this?
So good question. So when I'm doing an eyelid procedure, most of the time it's going to be a big open procedure anyway. So I'm already going to be in that space to release that arcus membrane. That to me is the key here. And so if we were to take fat from a person's abdomen and inject it into the lower eyelid, which I do frequently as well, oftentimes that just goes in like toothpaste. Some of that fat that I took out in this video here, going back to the start of this video, is fat that I have taken out from either the upper eyelid or areas of the lower eyelid. So this person had a lot of excess fat. So what I did was you can take that fat, you can take it into little pieces and morselize it. And if it's already there to use and we just need a half a cc or a cc of fat, why not use it?
Okay.
So, but in general, if I'm doing a lot of facial rejuvenation with fat, I'll oftentimes just put fat that I harvested from the abdomen in this space.
Do you also release like the septum and take the fat and redrape it and leave it attached? Do you do that as well? I've seen that, and I sometimes see that.
Yeah. So just for our listeners out there, we're just talking a little bit more technical here, but that's okay. So what Sam is referring to here is in this diagram here, what keeps the fat inside the orbit here is a little membrane across this called the orbital septum. All right. And in my practice, the orbital septum is a membrane that's notorious for scarring. So in general, whenever I'm doing a lid procedure, I just actually completely remove the septum. I don't want it there. I don't need it there necessarily. And so I just physically remove it. That way it has a less potential for scarring. The other thing that does is it helps allow this fat to reposition itself on top of this bone to blend that eyelid cheek junction a bit better.
Okay.
All right. So why don't we let's maybe go back to this pre-op picture here. And so Sam, tell me what you would do here, just in a nutshell.
I can start. So for this gentleman, as I had, and thank you for the analysis, by the way. I thought that was very detailed. Basically, I would like to break this guy down into about 3 different things: his brow, his upper eyelid, and his lower eyelids. So for his brow, I generally don't like doing large, what we would call a coronal type brow, or even raise the medial brow too much in males, because I think it can be very feminizing. So I would do what's called a temporal brow lift to start with. So for the viewers, that's basically making a 3 or 4 centimeter incision in the hairline, kind of the side of the hairline, through which I would get some elevation of the brow. Once I've done sort of restored and put the brow where I'd like to keep it, I'd remove a generous amount of skin from his upper eyelid. From the upper eyelid, I would start beginning to address the position of the lower eyelid as well. I would do what's called a canthopexy, possibly a canthoplasty. So technical difference for viewers, it's really whether or not you're removing a portion of the lower eyelid or just tightening it. More often than not, I generally just tighten the lower eyelid, and I'll do that through the upper eyelid. Like Dr. Pacella said, I don't think there's a lot of fat to remove in this gentleman, but I would probably do some contouring of fat of the lower eyelids from the inside of the eyelid, what we call a transconjunctival approach. I'd remove skin using a little incision in this crease below the eyelid, and I would add some fat using fat from the abdomen by injecting it into this dark line or the tear trough. So complex thing, basically addressing the brow, the upper eyelids, the lower eyelids, and the lower eyelid, specifically the position of it to try to restore that canthal tilt.
I agree. I think the brow is actually even more challenging in this patient because he has a receding hairline, so it's pretty far back there, even temporally. That's a challenge. I think, there needs to be some skin resection in the lower lid. Not as much as everyone always thinks, but a little bit maybe. The grafting for sure. And then, like you said, I agree with Sam, a generous upper eyelid skin resection.
And just to add on, one thing I always talk to patients about is the importance of a regular regimen of Botox. So I use Botox heavily for brow positioning. I think a lot of plastic surgeons do this at this point. I would basically tell this gentleman, I know you want to have one fix for your brow and not come back, but you need to get in the habit of doing Botox every several months. That's the way to create a brow lift in you that doesn't look artificial or fake, and you need to do that every several months.
Vitamin B, right? Vitamin B.
Exactly. Exactly.
All right. One other key point here I want to point out in this gentleman here is, there's a helpful little place where we look in the eyelid, and it's this area here called the lateral scleral triangle, right here, which I'm describing in this arrow. There's sometimes where you just look at an eye and you just don't know what's wrong with it. It's a little counterintuitive. Is it the upper lid? Is it the lower lid? What's the position of the lower lid? And so when I sort of try to look at the reverse of this, the lateral scleral triangle, this tells us a lot. So if you see in this gentleman, this angle here is rather obtuse or opened up, right? And so that tells us that his lower lid position is significantly down. Now, if someone had an acute lateral scleral triangle, that would tell us that lower lid position is up. And so that's a little an area that I like to look and I like to document in my notes ahead of time and in my photos, because it really gives me an idea of what I'm going to do with that lower lid, whether or not I'm going to shorten this lower lid or tighten it up substantially. So just a little helpful yardstick I use. All right, so let's jump into the before and afters here. So up above, we have the before, and after is down below. And so what I did for this gentleman is I did almost exactly what Texas Sam said. So I addressed this in 3 different procedures. So for the brow, I do a procedure called a brow stabilization procedure, or what's called a brow pexy. Excuse me. In men, we don't want to raise that eyebrow position at all. We want to really actually just stabilize it at the bony portion of the eye. So it's fairly easy during an upper lid procedure where we remove the skin to go inside and open up this area right here. And what we can do is place a couple sutures back and forth that go through or just underneath the skin to the bony component of the brow. And so that brow pexy acts to stabilize that brow so it doesn't drop down further. So that's a really good add-on procedure we do. And then in the upper lid, I took out a little bit of skin right here, and then we added a couple little droplets of fat across here just to fill in and give a little bit of volume off to the side. Now, you can see in the lower lid, we did address that bag pretty substantially here. And, so that fat got taken out, a little bit got taken out, a little bit of it got redistributed. And where I think this works really well is in this depression right here. You can see that really filled in quite nicely. Now, in this gentleman, particularly on this view here, you can see that canthal tilt is now much better restored from here to here. It's almost horizontal across as opposed to tilted downwards. The other thing this gentleman had, which is a little bit of a complex procedure, is in order to support the lid secondarily down, I ended up putting a little graft of some extra tissue in here to help support that lid. It's what's called a spacer graft. And that's something I do relatively infrequently, but in patients that have a substantial amount of droopy eye like this, with a lateral scleral triangle that's really, really obtuse, oftentimes some additional support is needed to the lower lid, and that worked fairly well in him.
Very nice results, Sal. That's a challenging case, and that's a really, really well thought out approach and a great result.
Yeah, I am particularly impressed that you got lower lid support without making him look cat-like, which is in someone who has a lot of lower lid laxity. I sometimes, you have to put a lot of support in, so you really fixate it. You just really hike it up, but then, you always worry about, are they going to look cat-like or change the shape of the eye? And I guess the spacer and sort of managing that was very nice.
Yeah, I don't know if the viewers of the podcast really recognize how this is not a run-of-the-mill case. This is a very challenging lower eyelid case, and these results are higher level stuff. So congratulations, Sal.
No, thank you. Eyelids are really fun thing to do for me. I did a specific fellowship in oculoplastic surgery. It's something I find exceptionally challenging. To me, it's one of my favorite procedures out there. So these are, when I see these patients come in, they're oftentimes sent from different areas. Different plastic surgeons may not have wanted to jump in and do the eyelid procedure. And I tend to see quite a few of these challenging cases. So it's always a challenge and fun for me to proceed with these. All right, great.
Yeah.
Pretty sweet.
All right. So let's move on to another procedure here. A little shift gears a little bit, and we're going to talk about male chest shaping. This is a procedure that I think is very, very common, particularly in younger men in their teens, 20s, or 30s. So let's kind of just start. I'm going to go first to Jersey Sam. Tell me your thoughts here.
So this, I'm just going to describe what I see for our audio listeners. He looks like a young man. I would say probably in his adolescent stage, somewhere in his teenage or young adult stage, has gynecomastia, which is enhanced or increased male breast development. It looks like it's somewhat asymmetric, so there's a little bit of difference in the appearance between the right breast and the left breast. There looks like there's an increase in breast tissue on both sides. The nipples and the areolas, which are the center part of the breast, do not look increased in size. The diameter looks relatively normal, for lack of a better word. And I would say it's not severe. I mean, there are different grades. This is pretty mild in terms of condition that most patients I would see present with.
All right, great. And Texas Sam, anything to add?
Yeah, I would echo Jersey Sam's comments tremendously. This is probably the most common male procedure I see in my practice, and other things that we traditionally will look at. Kind of the breakdown. Whenever I'm looking at these patients, I'm always looking at three anatomic layers: the skin, the muscle, and the fat. And so in this patient, when you're looking at his skin, you're always trying to look for this term that we call ptosis. And in some very severe cases of gynecomastia that you might see, not this patient, you're actually thinking about reducing the size of the areola, raising the areola on the chest wall. Do I need to remove skin? In this patient, those are not really considerations. The key problem with this patient that we're really seeing is underneath the areola, you can tell that he has dense breast-like tissue. It's breast tissue, it's not fatty tissue. And so in this patient, to remove that excess, I generally like some form of a heat modality. So I use ultrasound-assisted liposuction. The brand name we use is Vaser, which will sort of emulsify and liquefy that fat. And I'll spend several minutes on each side using a heated probe to try to dissolve that fat before making a decision about whether or not we even have to make a larger incision to remove that tissue. But this is a pretty straightforward gynecomastia case. I think, it can be treated largely by treating the fat and the breast tissue in this gentleman and not doing much with the skin.
Right. Yeah. So I think, so those are all great points, guys. And I think, what I'm oftentimes looking for is, number one is the consistency of skin, the elasticity of skin. And you pointed that out well. Some gentlemen, particularly older gentlemen that have a tremendous amount of ptosis or skin loosening, we may have to tighten up that nipple and areolar complex a bit more with some skin incisions. In this gentleman, he's younger, he's in his early 20s. His skin consistency is really nice. He's got a lot of elasticity, which tells me that's somebody that's going to respond very well to liposuction. The skin is going to contract around it, so I don't necessarily have to make a big open incision to do what I need to do. The second thing I think is very important to understand for our viewers is there are really two subsets of gynecomastia that we want to really understand. There's what's called fatty gynecomastia or lipomatous gynecomastia, which is male chest tissue that's mostly fat. And in this gentleman, you can see on the corners here, this is where he's got a little bit of fatty component and down below here. But if you feel and get your fingers in there, what you can also feel is something called glandular gynecomastia, which is this puffiness of the nipple that has this cone-like appearance here. You can really get in there and feel the thick, hard, fibrous component of this gynecomastia. And to me, why that's very important is those are treated with two very different treatments. So oftentimes with a procedure like this, I'm going to do a combination of procedures where I first start out with doing some liposuction, either power assisted or ultrasound. And we want to really get some of that fatty component, particularly on the lower portion of the chest. In men, I oftentimes want to leave the fatty component up top because that gives us the illusion of having a pec muscle. But I want to be really aggressive down in this lower portion of things. Once I'm completed with that liposuction for the fatty component, oftentimes I'll feel around and feel this nipple component and see if I still feel a fibrous mass or a fibrous component. For that, I'm going to make a little incision, a little hiding incision in the areola here or along the nipple, and I'm going to directly remove that tissue. And why that's important is I oftentimes see patients come in that may have had a gynecomastia procedure somewhere else where just the glandular component was addressed, meaning they just simply made an incision, removed it without paying attention to the liposuction component. And oftentimes that's a very difficult problem to fix. We oftentimes see a little bit of a double bubble on the lower portion of the pec, and there's an extra little wad of fatty tissue here. This area becomes really indented and sometimes even scarring to the chest muscle. And that's going to take a major reconstructive procedure to fix or get looking normal. Gents, any comments on that?
Yeah,
you can go first, Jersey.
Oh, okay. Thanks, Texas. Yeah. I agree with Sal about liposuctioning, and I agree that I usually leave some superiorly. I like to feel like I'm feathering it out, so it's like kind of a nice contour. If you go scorched earth with the lipo, I feel like it doesn't look quite as aesthetic. And then I do almost, especially my younger patients, a fair amount of direct excision of tissue. I feel when I first started, I was doing an inadequate excision, and then I'd have to come back. And I cannot tell you how many bad gynecomastia excisions I've gone back and fixed on others as well. I think I don't take insurances anymore. In the old days, when I did, there were a lot of hoops that patients had to jump through to qualify for insurance coverage, which included a full endocrine, like hormonal workup and all this other stuff. I don't worry about that so much now, but I do want to emphasize to patients, whatever, if there are factors causing the gynecomastia in the first place, like in a lot of patients, it's idiopathic, which means it happens. They go through adolescence and their hormonal changes and so forth. But if they got it through, substance abuse, particularly performance enhancing drugs, and they're still on it, because I see bodybuilders and so forth, I warn them that there's always a chance that this is not the condition can come back, or they can continue to have issues if the factors that started the gynecomastia are still in play after surgery.
Right.
Yeah, that's very, very true. A lot of older patients who are on testosterone, we'll see them develop this, and they don't want to get off of it. And so I've had patients where I have done gynecomastia surgery on them, and then they come back 5 years later and they know they're going to need it again because they won't stop taking steroids. I have a slightly different approach than described by you guys, slight variations. I agree that you have to be very careful of this lipomatous, more fatty region up here, but I differentiate between what I will use the ultrasound component of. So when we're talking about ultrasound energy, for the viewers, the modality that I think most of us use is called Vaser, and it's not actively doing suction at the same time that you're putting this probe in, but the probe will go in and it will emulsify the fat. And the reason why I think Sal and Sam are real careful with this area is they don't want to make this area look hollowed out. What I do like doing, though, is I like running the Vaser aggressively across the entire area first to try to make the fat softer so it doesn't protrude quite as much along this lateral portion of the chest wall. So I'll spend probably 10 minutes on each side actually emulsifying it so that the liposuction cannula, when it runs in, is basically like a hot knife through butter. When I spend that amount of time, still greater than 50% of the time, I end up making a small incision underneath the areola to remove sort of the denser glandular tissue that Sal was referring to. But there are not an infrequent number of times that I find that I don't have to make that incision because I've spent so much time with the ultrasound. It's mind-numbingly slow going back and forth with an ultrasound probe and not having fat come out. But I have found that sometimes I can avoid having that incision. But I think our basic approaches are all very much the same. You want to avoid over-resection of this area so that you don't have a indented, hollowed out looking areola, but you also want to avoid under-resection so there's not still areolar protrusion. So moving slowly and carefully and thoughtfully in this area is the key. Because like Sam Rhee said in the very beginning, this is a relatively mild case. So if you over-resect him, it can be horrible for the patient. But if you leave him with any bit of protrusion, he's going to wonder why he had this surgery.
Right. So. And just a point that Jersey Sam alluded to about insurance coverage and this type of surgery. So some insurance plan. So I still very much take insurance for most things that we can apply to the insurance company for. And insurance can sometimes pay for a component of this surgery. You really have, for our viewers and listeners out there, you really want to look at your insurance plan. Sometimes the specific language of gynecomastia is excluded from the plan, regardless of the cause or the symptoms you may be having. The other thing to keep in mind here is many times if we want to make this perfect, it involves both a insurance component and a cosmetic component. Many times insurance companies exclude the word liposuction from their coverage. So for example, if this gentleman came to see me, I would do a combination of direct removal and liposuction. Unfortunately, the liposuction many times gets denied, so we can't submit it to insurance. But the actual glandular removal or the open excision is covered. I think what you want to be cautious about out there as a patient is you may go to a provider and they may say to you, some of this is covered and some of it is not. What you don't want to make this decision on is finances. Okay. What I mean by that is you don't want to choose a procedure just because insurance pays for it. Because if you did that in this case, without addressing the cosmetic or the liposuction component, you would definitely come out having a noticeable deformity that's oftentimes very, very difficult to fix. You want the right procedure, regardless whether or not insurance will pay for it.
Yeah.
So let's move forward here. So this is, you can see before and after down below here. So what I did here is I did, as I described, a combination of a couple different procedures. So the first procedure I do is I started with some liposuction. So he had you can see here on the before pictures, he has a little slight scar or mole right underneath his left nipple here. So I used that to my advantage to do some liposuction through the site. The other thing I like to do when I do liposuction on a visible area is I want to oftentimes offset those incisions. If you look at somebody walking on the beach and they have a scar here and a scar here in exactly the same position, that's somebody you may think has had cosmetic surgery. So in a visible situation like this, I'll oftentimes offset these scars. I may put one here and one right here. So they may just look like a little injury scar or a traumatic scar or a mole for that matter. So that's one thing we want to do.
Sal, I want to point out your last picture, your side, your oblique, I think is flipped. So the bottom picture is your before,
you're right.
And the after's after.
Exactly.
Oh gosh, sorry.
I was getting ready for that old joke. Which is the before? Which is the after?
Because I was like, I got confused for a second. I was like, that one. What's up with that?
Because together early this morning. My apologies. Eagle eyes, guys. Eagle eyes. Right.
Yeah, so much better there. Yes.
Maybe I should stick to eyelids.
No, that looks so much better. I like that. There
all right, great.
Now we're actually impressed by your results.
Okay,
sure.
All right. So the liposuction component, I think, really addressed this segment of the chest and the lower portion. And then I also did a combination of a direct excision by making an incision right on the areola region, and then directly excising any fibrous component that I couldn't take out. So
it looks really nice. I have to say that a lot of patients, their number one goal is they say, I want to look good in a t-shirt. I don't want, they don't even really care sometimes about looking, without a shirt on. They just they say they want to look good in a shirt where it looks like their chest isn't poking out. And this looks very balanced, natural, even, and I can only imagine that he was really happy with it.
Texas Sam, thoughts?
Yeah, great result. I'm curious how you talk to patients about what their post-operative regimen will be like. Obviously, most of us use some form of compression, may or may not use post-operative lymphatic massage. Whenever we do cases with a substantial amount of liposuction, what's your personal approach to that?
So after surgery, the day of surgery, I usually use drains if I'm doing it at direct excision. I think that's really important because if fluid accumulates underneath the nipple, it's just a real bear to get off. So I'll usually keep drains in this segment underneath the nipple for about a week. And then I use a tremendous amount of compression. So I'll fit most of these patients with a garment, which is like a vest for men. It hooks up in the center. And it really adds some very nice compression to this area right here. After about a week or so, I'm going to fit them in a little bit more of a subtle garment that's a t-shirt component. And this t-shirt I order special from a company. There's many companies on the internet that can make these gynecomastia compression vests. These are nice because they're like a tank top type of t-shirt. And they have a constricted band right over the lower portion of the chest wall. And I think those really work phenomenal because most of these patients are going to go back to work or school within about a week afterwards. They don't want this big bulky vest underneath a t-shirt. It'll get hot. So this sort of customized t-shirt really adds this compression. I'll usually suggest 6 weeks of compression. knowing at best I'm probably going to get about 4 weeks out of them. So I'll usually shoot higher for compression, and I think that's really key.
Interesting. Okay. So I have a slight variation in my protocol, but basically the same principles. I don't use drains when I do these cases. I don't use that t-shirt garment, but now that you've mentioned it, I'd like to learn more about that. I think, like you've said, compression is very important, and finding a garment that people will wear for a long period of time is very helpful. I also find post-operative massage to be very helpful. I wasn't a big believer in that until a few years ago. But now I think either endermology lipomassage, which is what we do through our practice, where once a week patients will come in and they'll basically have a targeted treatment to try to help get fluid sort of built back into the lymphatics, helps tremendously, or just traditional lymphatic massage helps very well. Because like you said, getting people to wear garments for long periods of time is critical for the results. If people don't necessarily want to do that for a long period of time. But I think the key that we both have, and I'm sure Jersey Sam would agree with us, is compression and getting fluid out as much as possible is the key to getting the skin to redrape in a manner that's going to lead to a great result.
Yeah, I agree. I do sort of a mix of what you guys do. I don't use drains so often, but I do use the compression vest, and I do really bind the crap out of them when immediately. Some patients opt for massages, some don't. That's optional in my practice. I think that I do agree that the recovery is a little bit slower without, but it's really patient's choice on that one. And I find compliance is sort of an issue with my younger patients. Older patients tend to wear it for longer. But you're right. It's about getting the fluid out whatever way you can. It's about compression, and it's about making sure the recovery goes smoothly.
Great. All right, I'm gonna go back to our regular view here. Okay. Right.
So I think that those were some awesome cases. Really appreciated. I always learn so much watching your guys' cases and listening to you guys talk about it. It's funny because we all deal with the same types of challenges, and we all approach them with the training that we came with, but also other training and then our own experiences. So it's really cool to hear that.
Yeah, I think Sam, what I think is really nice about this forum and this venue here is that we're all in different parts of the country. I'm in Southern California. You're in the New York City, New Jersey area, and Texas. Sam is, of course, in Texas, and and so. And I think it's important for our viewers and listeners to understand that, patients regionally in various parts of the country are looking for different things, and everything's bigger in Texas. It may be a little bit more steen or smaller in New York. And I think that kind of hints to our training that we've had, that we approach things very similarly, with the caveat of our own personal experience in the region where we live in.
Absolutely. Just to echo their sentiments, I learn from you guys every week. I think we're all very good plastic surgeons. I think we all have busy and successful practices, but there's a lot to be learned from our colleagues. And so this has been an incredible venue. Hopefully people listening on the other end are getting something out of it, but even if they're not, I know I am.
Agreed. Yeah. Let's talk. We got some time left. Let's talk a little bit about non-surgical stuff. I'm going to put up one of the news items, which I think is relevant, and then we can talk about our approaches to men and non-surgical treatments, as well as talk about your take on this. So basically, this is a news item about Revance. They have a new Botox variation, which they submitted a biologics license to the FDA. It includes phase 3 trials, and their Botox lasts longer. It's about 6 months based on what they saw in their research, as opposed to, say, 3 for what we normally see with our current Botox treatments. So what do you guys think of it, and what do you guys do with your Botox or other non-surgicals with your men in your practice?
I'll start with that one. So, just for the listeners out there, Botox is part of our language. It's like Vaseline or Q-tips. Like, it's something that we know, but it's not the only neurotoxin that's out there for treating wrinkles of basically the upper 1/3 of the face. And the interesting thing is, though, even though it's not the only one, right now it has 3 competitors. It has over 95% of the market share. It is any competitor that tries to come out for Botox sort of encounters this juggernaut, which is both an amazing product, which is Botox, an amazing company that backs it, and the fact that it's just part of our popular culture. But I think Revance has the potential to be different, in the fact that it's the first competitor to Botox that's out there that lasts for longer. So specifically thinking about male patients, and when we were talking about gynecomastia, we talked about compliance specifically with compression garments. It's hard to get people sometimes, particularly male patients, to come into the doctor's office every 3 or 4 months for an injection. Even though 2 months may or may not seem like a big deal, it is a big deal. Getting a treatment twice a year as opposed to 3 or 4 times a year could make a huge difference in terms of its attractability. It's an interesting company too. It's a publicly traded company that most of our viewers have probably not heard about, but they've been making moves over the last year and a half where they've started to acquire some other companies, including a European filler company, and most recently a platform called HintMD, which is used for a subscription model for paying for these services. So I think this is something to watch out for. I think it's going to be potentially a game changer in the world of non-surgical aesthetics.
Yeah, I agree with Sam. It's I think when we look at the male population that uses Botox, it's most patients are still actively working. They may be in their 20s, 30s, 40s, 50s. It's difficult to get away for an hour from the office to come in for a treatment. I mean, just think in your own lives, your dentist recommends you get your teeth cleaned twice a year, and that's a challenge to get on the schedule, right? So Botox treatments 4 times a year is a challenge. So I think this is going to be a great value for patients. It's probably going to come at a little bit of a price premium compared to the other 2 products, just with the extended longer acting use. But I think it's going to be great for men.
I hope it pushes the price point down for all neurotoxins so that it becomes more and more affordable for everyone. I think that would be also helpful for, you're right. It's so funny. I feel like I have 2 patient populations, one who just can't wait to come in, and they come in like even before they really need to come in, because they're so afraid of, anything wearing off. And then the ones who will, drag their heels forever. And then by the time they come in, they look,
haggard.
Yeah, really. Exactly. So, yeah, I agree.
That's great.
So now I find that with a lot of my male patients, when I do Botox, I really have to, I'm not a big pusher of product, but I really feel a Botox alone for many of them is not enough. I have to push a fair amount of filler, particularly for some of the deeper glabellar or forehead, wrinkles. And I feel like just to get them to a rested or natural appearance where they're looking what they want, I have to sort of do multimodality type of treatments, and a single treatment of just Botox isn't going to cut it for a lot of them.
Right, I think. Go ahead.
You go, please. You started. Go for it.
So I think many men sometimes, at least in my experience, men are coming to the game of Botox probably in their late 30s, early 40s. That's when I see them start to do some of these treatments. Whereas in women, I do think that age comes a little earlier. And so by that time, men have developed static wrinkles in their forehead and face, much more than women, I believe. So, oftentimes when we see these sort of static wrinkles in the face with just sitting at rest, those are difficult, if not impossible, to treat with just Botox. So I agree with you. Most men, I think, are going to need a little bit of a filler too, particularly if they have a deep static wrinkle in the glabellar area.
I completely agree with that. And I think that's true for both men and for women. In my patient population, I've seen more and more younger men coming in for Botox, men in their late 20s, early 30s, particularly in the last 2 or 3 years. There's been a huge uptake in that in my practice. So I haven't had to necessarily push a multimodality approach more in men versus women. It's more, again, basically based on whether or not their age at which they're coming in. In Texas, we have a lot of sun damage as well in patients. So there's a multimodality aspect that involves a lot of resurfacing as well for our patients.
Cool. So we've hit the 55-minute mark. That's pretty good for us. And I know I'm sure we all have plans for Father's Day. Maybe not surfing out on the beach like California Sal, but we have our own activities to do.
I'm gonna try and do a little of that today for sure.
Yeah. So is there anything else that you guys want to add about anything about dads, about fathers, about the treatments we've been talking about?
You know, I think this has been a really instructive conversation. Wish both of you gentlemen a happy Father's Day, and happy Father's Day to your fathers as well. And thanks again for a great opportunity to learn from you guys.
All right, Jen.
All right.
Father's Day.
All right. Happy Father's Day, guys. Take care.
Take care.